Professor Dr. Gautam Saha as chairperson of this session. Professor Dr. Kalpana Srivastava is not able to join today's session, so she has another talk going on in other session. I now request Professor Dr. Gautam Saha to conduct this session. Dr. Gautam Saha, he is the Director of Clinical Brain Neuropsychiatric Institute and Research Center. He is the President of Indian Psychiatric Society. He is the Vice President of SARC Federation of Psychiatrists. He is also the Vice President cum President elected for Indian Association of Geriatric Mental Health. He has many publications in national and international presentations. I now request Sir to conduct this session. Thank you. Gautam sir is not here. We will be waiting for him for another 5 minutes. Dr. Kalpana Srivastava, she is attending another session. She'll be joining us shortly. I request Dr. Gautam Saha to conduct this session.
Good afternoon, ladies and gentlemen. It is a great privilege that in the industrial psychiatry organizing a hello. Can you all
Yes, sir,
hear
you're
me?
audible. Yes, sir, you're audible.
Yeah, thank you. Good afternoon, ladies and gentlemen. It's a really great privilege to chair a session in the annual conference of the industrial psychiatry. And I am also honored to be a co-chairperson of Dr. Seshagiri Rao. And today's we have two eminent speakers. One will speak on the COVID experience as a psychiatrist in UK, and another one is my dear Dr. M.S. V.K. Raju, who was my president when he will speak on the psychological aspects of the fishery industry. It's a great privilege. It's really in the COVID-19 situation, there is lots of mental health problem. In fact, from Indian Psychiatric Society, we have done a study on it, and where it showed that almost depression was 10%, 9.8%, anxiety disorder is about 35.6%, and moderate level of stress is about 71%. And so the level of mental health problems are very much increased during this COVID period. So role of a psychiatrist is immensely, and it was understood by all the branches of the medicine that COVID-19 situation is not only tackled by the physician only, it should be managed by psychiatrists or psychological or mental health professionals as well. By this, I hello.
Yes, sir, please continue.
I have finished already. I want to hand over my mic to Dr. Rao. Dr. Rao, please.
Yes. Shall I start my presentation, Dr. Saha?
Yes, sir. Yes, sir.
Yes. Good morning, everybody. Good morning from London, and good afternoon to you all in India. I've been waking up this morning because I'm following the Indian time, because I'm following the Indian cricket test match between India and England. First of all, let me thank you all profoundly, particularly Dr. Razu for inviting me for this session, and for Dr. Saha for introducing me to this session. So I've been practicing in the UK from the last 25 years as a psychiatrist. So I will share my experience as one of the first COVID sufferers, and also I will take you through my experience as different perspectives as a doctor, as a medical director, and as a how we suffered as an organization, and also to see whether there are any lessons that could be learned from India, or any learning points, because we were the first sufferers here. So we all know COVID is a pandemic of unknown proportions, because one of the interesting thing about pandemic is we don't see the generation. I think probably if for the next pandemic, none of us will be there existing here, because the pandemic cycle it goes usually in 100 years. So none of us knew, none of us have the experience, none of us were prepared. Particularly in the Western world, so far they thought they are immune. They are immune to these infectious diseases. And whenever there is anything about infectious diseases, they all thought that is a third world phenomena, and they're immune. But interestingly, the Western countries are the most severely affected in this pandemic. So the other problem we faced was there was no experience, there is no training, there is no strategy, there is no preparedness, because we all know, all the eminent doctors in this conference, none of us had any education, medical education, and in our medical school or further, we never read, or we never were taught about how to manage pandemic and what are the complications in the pandemic. So, and just to compare with Indian situation, in India, I think we are much more well-versed with the infectious diseases, because infectious diseases are still a big issue in India. So we have more preparedness. The very much sanitized versions of the Western countries, where infections, the communicable diseases particularly, are not a big issue, I think their preparedness is much more low. So that is the background. And just to give a picture about the COVID in the UK, it all started in March, when it was going in Wuhan in January. Nobody thought that we will be in the front line very soon. So the panic started when a lot of people contracted this illness in the Alps, because a lot of the Britishers, the Brits go for holiday in the Alps for the skiing season, and when the lot of cases started coming, they didn't know what to do, and all of them came back and brought the COVID to the UK. So I'm just before going through that, I just want to just touch upon the nature of the beast. So it is just not a medical, COVID is just not a medical condition. It is a public health crisis. It's a social problem. Social problem in the sense that, we are in the third lockdown in the UK, and you can see my hair, you can see everything. I didn't have any haircut for the last 3 months. So the last lockdown, this is the third lockdown. It started in the 1st of January, and it is still going on. And the roadmap laid by the Prime Minister of UK shows that until the end of June, we don't have normal life. There will be some restrictions. So, and the lockdown is implemented very strictly here because of the number of cases, particularly in January, where they had a second wave. So this is completely unprecedented. The social crisis, I think once the infections rates goes down, I think we will have a social pandemic about the effects of this COVID. And that's where the psychiatry will have to play a major role. The psychological problems are enormous. And because the outdoor life, the social life, and British pub, going to a pub is a part of the British culture. And if you don't go to the pub, I think they miss that social life a lot. And I've seen so many cases of depression, of a lot of low-grade anxiety disorders because of this lack of social contact. And I need not say how much effect this COVID had on the economy, on the political turmoil. We see the big people, the presidents changed in the world. It caused a lot of political upheavals. And the other interesting thing, what we are observing is the intrafamilial dynamics. I think this is more of, in the UK, you may see it more than India, because what I observed is, in India, there is still some social contact. Apart from the first lockdown, people are still having some kind of interaction. Keeping the effect of that on the infection rates aside, here the lack of social interaction and the encapsulation of a family within the four walls is causing interpersonal problems. There are high rates of domestic violence, and in fact, the government has to come up with some special measures to combat this domestic violence arising from the COVID. So there are enormous problems coming out of this infection. So I'll quickly take through my own experience. It was mid-March, exactly this time, I think a couple of weeks after this time, 1 year ago. So we were getting some kind of cases that saying that somebody had this infection, somebody had, the fever. So that was the time when, if there are a few cases in the town is being isolated, and there are some measures put in place. The lockdown has not yet come. And my wife started having the symptoms, and we thought it's just body pains. But she said, when she was picking up the kids from the school, she rang me and said, "These are the kind of pains I never experienced in my life." So that sounded alarm bells. And the next day she had fever, she had cough. And by the time we were contemplating, I contracted these symptoms. And at that time, there were no tests in the UK. There is no COVID test in the sense that you need to go to a center and there is a huge scarcity. So we started isolating, and the symptoms really were relentless, and they went on for 14 days. And my wife, particularly, was a high-risk patient. One of the interesting phenomena we thought, and in fact, a scary phenomena was the services have shut down. The GP services, the primary healthcare, which is the first point of contact for us in the UK for health, the GPs have shut down their services, their hospitals, and they said, if you have COVID, you should ring this number. And that number is manned by non-professionals, and they are just repeating the same well-known precautions. We are not getting anything. And the emergency says, if you have these COVID symptoms, don't come. And it was a situation where people were suffering within their houses, and a lot of people died. If you look at the first wave of COVID, where nearly 50,000-60,000 people died in the UK, a lot of them died with lack of medical help. And the whole service went into a meltdown. And only the emergency services were working, and they could not cope. I have to say that we are in a way very lucky that we survived. In hindsight, I can see we went through a very severe disease, particularly my wife more than me. I was relatively healthy in the sense that I never called off sick in my entire career here. For the first time, I had to call sick, and it was so debilitating. The body was so weak. I lost 4 to 5 kilos of weight, and it took me nearly 3 weeks, the whole thing from day one. At the end of third week, I was able to go to work. And if you look at the situation at my workplace, it is very dire. A lot of staff went off sick. The patients had COVID, and the most worrying thing at that time was we did not have any PPE, because you can see by this how unprepared even the so-called developed countries are with this COVID. And we had this ethical dilemmas where some of the staff were getting some PPE from the market and they're wearing. So the ethical dilemma is, should you allow them to wear the PPE, and will it cause discrimination? Debates like this were going on. And then the government at that time was giving so many bulletins, so much information, but there is no action in the sense that the basic things were missing, and a lot of this information which was coming was contradictory. I think one of the things we can learn from this pandemic is information management. So in a large organization, how to manage the information, how to streamline the information, and how to process this information and give it in a form that is implementable is one of the major lessons we can learn from this pandemic. So when I got back, we got into the role of supporting the staff. I think the personal experience I had as a patient helped me to see what it is like, and we are able to help the staff, help them come back to work, provide them counseling. I think the staff morale was important. I mean, to support the patients, the staff should have that psychological robustness, and we put a lot of systems, and we worked on that. And all the hospitals, I work in a long stay hospitals, and the visitors are banned, and there is no face-to-face contact. It was total isolation, and that had effect on the patients, because going into the community, going outside is a part of their rehabilitation, and it was difficult to explain to them why we are stopping it. But as time went on, they were remarkably resilient, and they were able to understand that. I think I'll share some of the experiences as an organization. If you ask us what helped us as an organization to survive and to come out of this first wave, the first crisis, is openness, honesty, and transparency. There were a lot of things we did not know. I think there was nothing wrong in sharing with the staff in an open forum, saying that, see, these are the things we know, these are the things we don't know. we are all in it together. The anxieties you are carrying, we are also carrying that. But the thing is, we are in a leadership position. We just need to take command of the situation, and we try to put all the we try to cut off all the contrasting guidelines, and we had a little committee which processed the information and gave that information which is implementable, which is useful to the staff, which is simple. And also we had a separate ethics committee. There were situations where we have to seclude patients because they are not isolating. If a patient is showing symptoms, we encourage them to isolate if they isolate, but if they're not isolating because of their mental illness, we have to seclude them in a room on the basis of containing the illness. Then there is an ethical dilemma. Are you secluding for his physical illness or mental illness? Are you legally empowered to do that? These are the dilemmas. So we set up an ethical committee so that they can independently look into it and take everything into account. And we involved the staff in all the critical decisions. I felt the most important thing which was helpful was being there. I think we have to leave our offices and be there with the staff to show that we are in it. And by gaining that trust, we were able to get through the first wave. The other thing which we thought about is the flexible working, because the schools are closed, the children are at home, some of the staff are not able to come, and we have to work around that. There was, I think, as psychiatrists, when compared to some other places, I think the psychiatric hospitals did very well, because the ingredients of empathy, compassion are built into our profession, or built into our day-to-day practice. And also we are very good in telling what we don't know with our patient. We thank our patient, and we have that the therapeutic relationship. I think all of those worked in our favor in my organization. And coming to the second lockdown, because by April, May, it was on the peak. By June, it was decreasing. By July, life was normal to an extent that UK was encouraging people to go out and to use the pubs, and they're giving restaurants half the meal for half price. So all these kind of schemes were going on. Help to Eat is the scheme, so that you can revive the restaurants and all the eating places. But unfortunately, the rates again started rising. They had another lockdown. They had this tier system. It was completely relentless. And in winter, we had this second wave, the third wave, the second wave, and which was real, because people ask, will India get a second wave or not? The answer is, I don't know, but I wish it should not happen. It should not happen there. But here it was during the second wave, that is during December, January time, we were very well prepared. The PPS were all over the place. And in general, the British public are very law-abiding, rule-abiding. I think they say, there is a joke that the British people love to be in the queue. So with that, even with that kind of discipline, the second wave was very much there. So I think it is to do with the natural course of the virus, and it took a huge toll. But on this occasion, I think the people are very well prepared. It was very well managed, although the numbers look very high. I think there are 120,000 deaths in the UK. When you compare that with the base population, I think even it is higher than the United States per 100, if you take the number. So what it shows is, however much you are prepared, if the pandemic is coming, it will take its toll. So the other interesting thing I just wanted to mention here is, which may be of relevance to you, is now, after 1 year of carefully following this and having a lot of discussions with colleagues like you, I started believing that Indians in India have some resilience to this illness, because whatever we may talk about the figures, the government figures, whatever it is, but what the fact of the matter is the hospital beds, there is no crisis in the hospital beds. If there is a pandemic of UK proportions, I'm sure all the private hospitals, all the government hospitals, there will be a panic, but it is not happening. So it is real that it is not as severe as here. We don't know the reasons, but interestingly, the same ethnic minorities, we call it as BMAE, Black and Minority Ethnic Groups, in the UK, they have a very high incidence to an extent that ethnicity, being Black or Asian, is marked as a high risk factor along with age. We don't know the reasons why African countries and Indian countries are doing very well at home, and why the same people who are in the UK are getting are dying more. In fact, if you look at the doctors and nurses who died of COVID in the UK, overwhelming proportion, very overwhelming proportion are from these communities. There are so many reasons. We will know, science will tell us in due course, but some of the hypotheses are, although the Black and ethnic minority population represent only 4 to 5% of the UK population, in the NHS, in the National Health Service, they represent at least 40% of the population. And all these people are in the front line, working in the accident and emergency, working in the very, very frontline jobs. So the rate of infection, the rate of exposure is very high. So, these are the kind of issues. Dr. Saha, how much time have I got?
Hello.
Hello, how much time have I got?
Yes. This is, I think, another 5 minutes.
That's fine. That's fine. That's fine. Yeah, because I've been in the front line of COVID, and I lose time if I start talking.
Yeah. Sir, you can continue.
Yeah. So I will talk about the vaccine and the UK experience. UK is in the forefront of vaccine delivery. I saw the figures just before this talk. Per 100, they calculated what is the vaccine delivery so far per 100. Israel is at the top, nearly 70 to 80%, followed by UAE, nearly 60%. UK is the third, and it is the large country which is on the top, like 31 people per 100 got vaccinated so far in the UK, as opposed to 23 per 100 in the US, and also 1 per 100 in India and 3 per 100 in China. So altogether, out of the 65 million population, as on today, 21 to 22 million people got vaccinated. We all got vaccinated. But interestingly, there is some resistance to the vaccine in certain groups. And this is based on some religious reasons, and this is based on some kind of myths and some rumors circulating. And I think this is where, again, we as psychiatrists have got a greater role to play. All the doctors, all of us took a front line and showing to our staff by leading by example that we took the vaccine, it is safe. I think we all need to get into that mode, because we see a lot of these pictures of people showing that I had the vaccine on the social media. I personally think it is a good thing. It should, especially the role models, the leaders, the community leaders, the doctors, they should show to the public that vaccine is safe and we are taking the vaccine. So just to mention about the vaccine intake. So once the vaccines are clearly working, there is evidence. They did this study in Scotland. The vaccines not only are protecting the people, but they're also spreading they're also reducing the spread of infection by 90%, 80 to 90%. So vaccines are shown to be of proven efficacy. And we got an answer. I think once the pandemic subsides, once the medical issues subside, I think we will have the real pandemic of the psychiatry, the psychological problems. A lot of the problems coming from the social isolation and all this will come to the fore. And I think we are the second line. Our medical colleagues have fought the first battle. I think we as psychiatrists should be prepared, geared up to clear all the psychological kind of impact that COVID has had on us. Thank you very much for giving me this wonderful opportunity. It's a great pleasure to be with you and share my experiences. If you have any questions, I'll stay here and I'll take the questions. Thank you very much.
Thank you, Dr. Rao. It was an excellent presentation, very lucid and elaborative, especially when you talk about the confusion regarding the vaccination. In a lighter note, we told that if you don't publish your selfie, it will not effective. It is a lighter note, but it has effect. Because people, those who are confused, at least if a doctor or celebrities, those who are, if they post that they are taking vaccine, it is definitely there is some awareness to the people that the vaccine can be given and it is effective. Those people are also taking. Thank you, sir. Next speaker is our past president of Indian Psychiatric Society and Industrial Psychiatry, Dr. M.S. V.K. Raju, Brigadier M.S. V.K. Raju, sir. And he'll talk on psychological aspects of fishery. Sir is always very lucid and we are eagerly waiting to listen him also. I request, sir, please go ahead and present.
Sorry to interrupt, sir. Thank you, Seshagiri, sir, for sharing your experience with us. Dr. M.S.V.K. Raju, sir, will be joining us shortly. He's on his
Then
way
you
to our
can take any
department.
question. If there is any question, chat box, please see. Then we can.
Yes.
Dr. Rao,
Yes,
you don't think that in this pandemic situation,
yes,
as a psychiatrist, I feel the importance of mental health and mental health professional. People will understand now much more than before.
Exactly.
What is your comment on this?
I think yes, you're 100% correct, and I think this pandemic of psychological disability is going to break out now.
Yeah,
because it is all in the houses, it's all in the communities, because there are more obvious problems. It is underneath. What we are seeing is a tip of the iceberg. I think there is a huge problem there. And if you look at these psychological stress factors for depression or anxiety disorders, you have all the risk factors here in this pandemic.
Not even that, sir. Domestic violence also increased during this lockdown period.
Exactly, hugely, and lot of interpersonal problems, because the husband will go out, he goes to job, he has his own social life. Now the husband and wife are locked in a house, and that is causing a completely different dynamic, and that caused a lot of problems. It's almost like a biggest social and psychological experiment that has ever done. There's so much material there. And you're right, Dr. Saha, we will have a big role to play.
Thank you.
Yes. And I think as from Indian Psychiatric Society, you should kind of, be prepared.
What we have done, sir, number one, already just some days before, it is a coincidence, you can tell, the Medical Council of India recognized our telepsychiatry practice.
Yes.
And from AIPS, Indian Psychiatric Society, we have made a guideline under the leadership of the then President Dr. Dalal. We have made this. Dada is with us, Dr. Professor Brigadier M.S. V.K. Raju. Sir, he does not need any introduction. He is the past president and of Indian Psychiatric Society as well as Industrial Psychiatry. And if you want to add, ma'am, any introduction, please.
Okay.
Is the veteran of the Armed Forces of the Medical Services of India. He is the President of Association of Indian Psychiatry of India, ex-President of Indian Psychiatric Society and the Sark Psychiatric Federation, We are always proud of him. And he is also a board member and Zone 16 representative at World Psychiatric Association. Right now, he is the chair of the Award Committee of Indian Psychiatric Society and member of World Psychiatric Association. Formerly, he was a professor and head of the Department of Psychiatry at Armed Forces Medical College, Pune, and adjunct professor of research and interactive research School of Health Affairs, Asia, Pune, senior advisor and consultant, Armed Forces Medical Services, Delhi, and Commandant Military Hospital, Kirki, director of Paraplegic Rehabilitation Center and Queen Mary Technical Institute, Kirki. I cannot finish if I read all about him. The full session will go with that. I request, sir, Dr. Professor Brigadier M.S.B.K. Raju, please go ahead and present on psychological aspect of people associated with the free sharing. Thank you, sir.
Am I audible?
Yes, sir.
First of all, I would like to take this opportunity to thank Dr. Nimagatta Shashagiri Rao Garu for giving a wonderful personal experience as well as the issues which developed in UK. When the virus suddenly attacked UK, they were not unprepared, what sort of trouble they have undergone and all. I think all of us have gained for this experience from this talk. Thank you very much, sir, for joining us, sparing your time. I bothered you very short notice. Well, previous slide, please. First slide.
Okay, first slide.
First slide. Sorry, there's some confusion. First slide. No. You're going ahead. Back. Ask Nisha to stay here. Back, Jana. Sorry, there's some this thing now. We'll go back.
No problem, sir. You can take time, sir.
Back. Nisha, back. This is not the first slide. This is not the first slide. Somebody has to be here. Yeah. Well, sorry for the little inconvenience in the beginning. This is the place where I belong, originally is coast of Odisha. As a crow flies, this small hamlet is about 5 kilometers from the sea. And when I was young, a child, I could hear the roar of the sea at night, but not now. There's so much of traffic and noise, you can't hear the sea. But there are many fishing villages dotted on the coast, and their sustenance and the savior for them is the sea and the fish. In fact, if you walk on the beach, you smell fish, because the sand also smells of fish, because the women dry their fish on the sand. And the women, it is a common sight earlier on, some years ago, the fisherwomen come to the village with their dry fish before the sunrise. And in those days, the village was infested with wild animals. If you see the hill on the back, it's about 1 kilometer away from my house. It was, this crop is called hyenas dan in English. In Odia, it is called godhwadoli. There are any number of hyenas which descend down from the hill in the day and at night particularly. And these ladies were brave, and they will go before the sunrise even into the behind the mountain there and all. Next slide, please. How about you do?
Just dump display. Display. So this is the next one.
Yeah. Well, I am a farmer actually. I trespassed into psychiatry, and I take to the soil of the village like a fish to the water. And I was talking about wild animals. There is a small hill. It's about 3/4 of a kilometer from this place. It used to be occupied by about 12 leopards when I was young. But when I little grew up, they vanished. But I used to see dozens of wild bears there and all. So it was a wild area surrounded by hills and all. So I am somewhat of a rustic and bucolic when I talk about things. So when I heard that Gautam has consented to chair this session, I thought I must talk about fish. Well, the cultural norms and the community which I belong, I am not supposed to touch fish, leave alone eating it. But then I'll tell you why I am talking about fish. Next slide, please. अपने आप आ जाता है, gone ahead. Psycho, how do I go back?
Oh, so.
This is what the topic for today, psychosocial factors in fishing industry. I must confess, I do not know much about fishing industry, but I have some knowledge. Why I am telling you in next slide. So I thought we do not know much about the fishing people. And India is basically has got third largest fishing producing country in the world. Well, one fine day we thought that since we are in the coast and we see so much of fish, and fish farming apparently is quite remunerative, so why not fish farming? And this is the pond which our family owns, about 2 hectares of irrigation pond. And the hill behind on the left shoulder you see, we call it in English Brown Hill. In Odia it's called Kanchakudya, that belongs to us. So I thought, why not doing it? So we did, we purchased the seedlings from the government at a price, of course, and then we start feeding the fish. In about 6 months' time, the fish, we saw big fish swimming in the pond, clear water. We thought we are going to get some good yield. Since it is 2 hectares, we thought about 4 metric tons of fish. Yeah, this is the rohu. Next slide, please. And what happened? After about 9 months, I think we started the netting and we got fish. And how much we got? 170 kilos of fish. The lesson is that however educated you are and whatever you are, you need to know your fish. Fish farming is a highly technical thing these days. So just putting the fish there and feeding them with whatever you have doesn't yield anything. Things have changed. So we learned our lessons, but we are, my family, I mean, reasonably fair means we have. But imagine a small farmer who invested his whatever little money he had in that pond. And he found one fine day, he got about 20,000. His expectation was about 4 lakh rupees. How crestfallen he would have been, what a calamity would have been to him. That's what it is about fishing. Fishing industry in India is in a transitional stage. Fishing industry, first what it is, includes any industry or activity concerned with catching, culturing, processing, preserving, storing, transporting, marketing, or selling fish and fish products. So fishing industry does not indicate just catching fish from the sea and that is the end of it. There are so many connected ancillary industries and it supports so many people because of the extended fishing activity all around. The FAO of the UN says it includes recreational, subsistence, commercial fishing, and harvesting, processing, and marketing sector. So fishing industry practically covers primary, secondary, tertiary, even quaternary industrial setups, provides livelihood for 820 million people across the world, and provides 16% of the protein which is required for the world population. So it is a food and is also a source of economy. Next slide. Well, we are now 7.7 million people, but it's supposed to will go up probably at the rate we are producing 9.7 billion by the year 2050. Food security, the world's main challenge now. Per capita fish consumption increased from 10 kilo in 1960 to 20 kilo in 2016. Now I think it's somewhere around 22 kilos per year. Constitute about 17% of the global population intake of protein. Fish contributes that 17% of the protein requirement for the world. Global export of fish trade was about 143 billion US dollars in 2016. India produced a very major exporting country of fish. So it is a source of food and income both. Next slide. Wow, this is the map of the percentage of, percentage of fish protein people are having. India is just about 2 to 4 grams per day per capita consumption, very low. Where you see the Russia, East European countries, America, the Scandinavian countries, Australia, high fish consuming countries. So I don't know, we produce more, but apparently we are not eating more, and everything we are probably exporting. Next slide. So the UN has formulated, we all know, the Sustainable Development Goals. By 2030, everybody will be free of poverty and no hunger, good health and well-being to everybody, gender equality, life below water. This is the 5th number in the 17 list, gender equality, and 14 in the 17 list of the Sustainable Development Goals. Fish contributes to 5 major developmental goals of the UN Sustainable Development Goals. Next slide. This is a very important slide. The fish production was somewhere around 20 million tons per year in 1950. By about 1950, and the artificial fish culture was hardly anything. This is all capture fishing, fishing from the sea and other area. But gradually, as I said, the fish stocks dwindled rapidly. So there is a plateau. There is no further increase in the fish production, fish capture from the sea and all. It's all artificial culture. To the extent now, actually 2018 is almost 50% is contributed by fish farming, aquaculture. So that is a major factor which impacts the fish community, fishers and fishing community. Next slide. So taking all this into consideration, the Food and Agricultural Organization, the UN, formulated the Blue Growth Initiative. Blue Growth, which is emphasizes on the employment and livelihood, food security and nutrition, sound fisheries management practices, and support to healthy ecosystem, places these communities at the heart of all policies. The communities at the heart of all policies. India government also made a draft of the National Fisheries Policy last year in September. It is still not a policy. It is in a draft form only. I think they have taken many of these things into consideration. I will talk about that a little later. But the thing is that the fishers who fish, they do not come to have the fish which they catch. Because of the poverty, they have to sell that. And COVID has put more problems on them. We'll come to that a little later. Next slide. Yeah, this is the top 10 exporters and importers of India. Doesn't import any fish, it exports. If you see that India in 2006, it won so much of $1 million, 1.8 million of exports, and share is about 2%. Whereas by 2016, it is almost double of the share and triple the earnings. So actually now the government of India says we are number 3, not number 5. So India is a major fish exporter and doesn't import fish. So it contributes significantly to the economy of the country. Okay. Well, fishing in India has a large history. The Indus Valley civilization people also had fish symbols in their coins. And Kautilya's Ardhashastra mentioned a fish, and people down south of India have been fishing for 2,000 years. We have a long coastline of 7,500 kilometers. We have nearly 2 lakh kilometers of rivers and 2.9 million hectares of reservoirs, small and big, 2.4 million hectares of ponds and lakes, and we have a exclusive economic zone of 320 kilometers. You multiply by the coastline, we have 240 million hectares. So India has a potential to produce about 4 million metric tons of fish. And we are now, I think last year we produced 1.25 lakh metric tons. So a lot of potential there in the fish. It employs now 16 million fishers. Out of them, 9 million are still in the traditional form of fishing they do, and they have problem. Contributes to 1.03% of GDP. I said one of the top producing countries, and 33.441. The government of India says the target by 2025 is 1 lakh crores. So I think they will be able to meet it. Next slide. Well, it's all about the fishing. The fishing communities, fish worker communities are often isolated in rural areas and have poor access to markets. You go to the Konkan coast or the Odisha coast, you will see how remote they are, how they are poorly connected. Communications are poor, they're remote, they're ravaged by repeated cyclones and natural disasters. If you go to Odisha coast, the regular cyclones, super cyclones, low depression, this and that, hearing on the radio, fishers are advised not to go to the sea. It is a frequent, everybody hear this frequently on that coast, and same thing happened in the Western coast also. Fishing community are very poor, and they are becoming poorer, particularly traditional fishing community. High prevalence of informal work arrangement, there is no DST, no insurance, no nothing, underemployment, and seasonal casual employment. And in that, in monsoon season, they cannot fish. They have to see something to tide over the moratorium period. Labor abuse and exploited poor migrant workers. State like Goa, there are about 10,000 migrant workers are there from Jharkhand and Bihar, things like that. High post-harvest losses of already dwindling volumes. Volumes are already dwindling. Fish nets are coming empty due to poor handling, processing, and low storage facilities. The government of India, I think, is addressing to these issues now. These central schemes, integrated fishing development programs, various schemes are there. They're trying to help the fishing community to develop, organize better in marketing and storage facilities. And the central funding is there. And I think the central government had trained 60,000 fishers already. A skilled program, national skill program. They're trained how to do modern fishing and all. But people have misgivings because the traditional life is disrupted. Next. Now coming to the health of the fishing communities. Most hazardous peacetime occupation in the world, fishing. There are some articles from Wales, from Australia, from US, from Canada, various places. Everywhere, I think, mostly these studies are on commercial fishing. Traditional fishing, they're hardly almost nil their data on health. But most peacetime occupation in the world, because of high incidence of accidents and high incidence of deaths and injuries to limbs and back, high rates of hypertension, diabetes mellitus, obesity, musculoskeletal problems because of the constant bending, standing, cancers and mesotheliomas, particularly in the boiler room workers, in the engineers of the mechanical fishing boats. High rates of gastrointestinal, dental and dermatological problems in accessing healthcare. They say, in the Australia, Deakin University made a study, they say the doctors see the fishers as they look down upon them, subcultural. They say they are not equal to even farmers. So they don't accept their take their complaint seriously. So much so, about 36% of the fishing community don't go to the doctors because they feel insulted. So not all fishers are okay. That's what their slogan is. Not all fishers are okay. That is not okay. So, but still, in India, we do not have much data at all. Very sad. That is the accept general health. Mental health, positive empirical study. There are hardly any studies. I could just access two studies, one from Goa and from Mangalore. Positive empirical studies. 90% depression was found out of 1,000 fishers. They made a survey in Australia. 90% depression, much more than the general population. Suicide rate is high. Generally, they accepted double the rate of the general population. Again, there are no definite figures on this. 75% reported severe studies in the Mangalore study. 100% felt negatively affects well-being because they stay from the families far away. This is the commercial fish. So, and they always think of their family. They feel very not well in the fishing boats. And it is very severe stress. And actually 2% say dangerously stressful. Chronic job insecurity. They don't know whether they will earn enough to feed their families. But the bottom line is we need data. This is there. Some are very anecdotal, observational, impressional, but no definite studies. There is need for definite scientific studies, particularly this high-risk population. New technologies allow fishing fleets to double their potential power every 35 years. That we have seen fishing efforts increased considerably from 7.5 lakhs of tons in 1950. We are now producing last year 1.25 lakhs, 17 times increase in fish production. But daily fish production is remains same, means the fish stock is decreasing, you are fishing regularly same amount, further dwindling. As per the FAO study, about 35% of the fish population is already dwindled in the seas of the world. So that leads to poverty. Modern capital-intensive technology, where you invest in mechanical trawlers and whatnot, and the business model has come into the fishing. Superimposing existing traditional base, community-based fishing. India is somewhat in a transition stage, probably more towards business model. Single most important factor responsible for the poverty, the steep decline in the availability of fish. That slide I have shown. Quality in terms of quality, quantity, and variety. Current levels of earning leave little surplus. There's hardly much they earn. So as I said, monsoon period, now it used to be 61 days, now it is I think 45 days. They cannot fish because that allows the fish to grow. They cannot fish. Now they have to keep something to tide over this period of moratorium. Now, particularly in the COVID, they could not go to the fish at all. All the ships were docked. And they stored dry fish for to tide over the period. They had to eat it. Now, how they replenish it? So these are the issues. Further poverty is further complicated. Informal fishers are marginalized because of the business model, mechanized fishing. Burden falls on women. The man is not working. Traditionally, the man conducts the fishing, the women sell the fish. That's what I told. Fishing women used to come to my village. But then the man is not going to burden fall on the women. But then what happens? But the women do not get fish to sell because the traders pick fish from the landing site. The business, straight away they pick from the landing site and take to the market. The women are deprived of their traditional business activity. And that aids to the poverty. And that aids to migration. People migrate to small cities, big cities, seeking other opportunities. The Indian government is trying to rectify the situation by various policies. Next. Now, Indian government formulated national fishing policy is the draft form. It takes a lead from the FAO Blue Economy Initiative, productive integration with other economic sectors such as agriculture, coastal area development, and ecotourism to meet the goals of blue economy. Because fishing itself is not sustainable for the traditional fishing community. So they have to be diversified. But the criticism is they say it is all export-oriented based on capital investments, business model, as said, silent on protecting fishing communities as per the National Fishers Worker Forum. There is a National Fishers Day also in India, July 10th, every year is celebrated, and ecologically hazardous because their model is catching more fish and selling, exporting. So you are actually fishing more, dwindling fishing stocks will dwindle further. That in long range, probably it is ecologically hazardous. So many economists, experts are having misgivings about the national fisheries policy. Fortunately, not yet a policy. Probably the stakeholders will sit together and discuss with the government. Probably they can avoid in this way, like the farmer situation which is developing, particularly in the north of this country. Next slide. Well, the COVID. Lockdown affected day-to-day earnings. There is no fishing. There is no fishing to sell, fishing to produce. Because the physical distancing norms, only a few fishermen were able to buy fish to sell from the landing site, whatever is available. They have to keep their distances. But then people are not there to purchase. And people do not want to purchase fish to end store. But fish you see in the morning and evening, The window period to sell the fish is very small, contributing to the economy. They, as I said, they ate the dry fish stores which they stored for the monsoon moratorium period, further adding to the poverty. Because of lack of storage facilities, quantities of fish had to be discarded. Particularly this has happened in Goa. So all these things is not very simple, and just giving an overview. This is very complicated because fishing, traditional fishing, community based. There are so many community fishing communities, and each have their own cultural beliefs and all sorts of things. So sitting in one by bureaucrats and people in office probably cannot formulate such a policy for such a large coastline, large fishing area. Next slide, please. So the experiment has to improve our situation. So that's all I thought from the slide. Thank you very much for listening. I hope I was able to touch on some issues which are relevant to fishery. Thank you.
Thank you, sir. It was an excellent presentation, at least in the new area. Honestly, I never think that this is the area should work. And you are maybe the pioneer, one of the pioneers in this field.
Probably
And
you
we
will
have
start
seen
a
so many
specialty
people
section.
associating. That we have seen so many, especially in this area where I reside, in the clinical practice associated, those who are with the fishery, I mean, these fishing industries. It includes almost from the basic level in the rural area, who catches fish to the high, who are the owner of the arath, we tell is arath, or the wholesale marketing actually. From there, they are really very much anxious regarding not only that, those who cultivate, those who are doing the fishing, well, they are the pin, they are telling it pin. They are very much anxious because within this time period, they have to reach. So time pressure was there. Not only that, the business is a business. Those who are business, doing this very business, one day they may be earn in a crores, or in one day they can lose the same amount. So it is definitely like other business, it is much more mental pressure relating to all these things. And definitely whatever you mentioned, these are the other factors. And he also mentioned some studies. So it is a great presentation, sir. Now it's open to the house for question.
Thank you, sir.
Any question? Dr. Rao?
I learned a lot about some new things. I never heard, I never imagined that there is so much, in the industrial psychiatry. It's a very, very interesting talk, Dr. Raju. Thank you very much.
Thank you. Thank you, Doctor.
Sir, one thing also I have seen, there are lots of patients, they attend and they had what I'm telling you, sometimes some fishes are infected with something that they died like some infection. There is a huge loss. They became almost psychologically broke down, and it has a huge loss, like prawn and all this business. They export the fish from India to outside. So it is definitely the psychological aspect in the fishing industry is very important. We should do more studies in this field.
Because the business model, certain types of fish only are produced. The traditional fish on which the fishers used to subsist on, they are vanishing very, very fast. There's another issue. And since they are exported, they become expensive. The fisher who catch fish is unable to eat the fish which he is catching. That's another situation. And it can't fish. Actually, people underestimate the micronutrient the fish give, besides the protein part of it. So they are very poor. That they cannot have. So it affects their nutrition.
And especially in this pandemic period also, all export are stopped and they faced very bad times for each of them.
You could store only for a limited period. Thereafter, they had to discard.
Yes, sir. Yes, sir. Yes. So, Madam Nishita, can I conclude this session over here? Over to you.
Thank you, Dr. Rao Garu. Thank you very much.
Thank you, Professor Dr. Gautam, for chairing this session. I also thank respected speakers for such an exhilarating session today. Now, this brings us to the end of the second day of 18th Annual National Conference of Association of Industrial Psychiatry of India. These enriching sessions would help budding psychiatrists like us in understanding the impact of COVID-19 pandemic on general population and healthcare workers in dynamic aspects. I cannot end today's session before thanking all the great guest speakers, patient chairperson, and the wonderful delegates without whom these amazing sessions would not have been possible. We wish you a brilliant day ahead and keenly expect your active participation tomorrow. We'll be starting tomorrow's session at 9:30 a.m. sharp. A link will be sent to your email for the same. Thank you.
Thank you.
Thank you very much. See you, Dr.
Thank you, sir.
खत्म हो गया नहीं तो खत्म नहीं हुआ नहीं